So my name is Ioannis Bakolis. I'm a professor of public mental health and statistics, and I'm based at King's College London. And I've been asked today to provide kind of an overview of what we mean by implementation science. So I'll try to make a little bit the case of implementation science. And I've been asked as well to provide an example from the healthcare kind of services research field. However, I mean, like at the end of the presentation, I'll try to adapt it more of how we can use that when we are evaluating and when we are evaluating the effectiveness and implementation of environmental related policies as well. But before we do all this, I would like to tell you a story. So this is a story that started in an operating theater room. And this is the story of the World Health Organization surgical checklist. It's probably one of the stories that actually make more emerge in the field of implementation science. And the World Health Organization surgical checklist was introduced for patient safety, and it's like kind of a simple approach. So it's a checklist that a surgeon will have before and during a surgical procedure, and will tick all the relevant kind of elements that he needs to consider during before and after the operation. So it's a very easy to implement. It's something that you can do in a very few minutes, and and the reason for that is not only to increase patient safety but also to reduce surgical complications. And the first study around the effectiveness of the surgical safety checklist was taking place in 2009. In 2009, it was a kind of a worldwide study, having centers from different countries. And the first results that were published at the New England Journal of Medicine show that the surgical safety checklist, when was compared with kind of practice as usual, reduced major complication rates in patients by 36%, mortality decreased by 47%, and the post-operative infection decreased also by 48%. So some kind of large and significant clinical difference and some significant effects on the surgical safety checklist. And this taken by storm. So within weeks of publication, this became a national policy across the UK, and all hospitals were asked to implement the checklist within 12 months. So this is something that usually doesn't happen in healthcare. Something that was evidence-based could actually be rolled out and implemented very quickly within a national health service system. And there were further evidence around the effect of the WHO surgical checklist on patient outcomes, and there was a randomized control trial as well that kind of replicated the clinical significant differences that we're seeing in terms of the effectiveness of the surgical safety checklist. And again, there was a big reductions in complications, big reductions in mortality, and in post-operative procedures. And when this was trying to implement it at scale for the first time, this was we're trying to introduce the surgical safety checklist within all hospitals and within Ontario, Canada, so in a quite wide area, and large number of patients take into place, because, as we say, there was like kind of a population level type of implementation of the surgical safety checklist. The 30-day mortality that was observed pre-introduction of the checklist, when it was compared again with treatment with surgery as usual, was 0.71%, and post the checklist was 0.65%. The complication risk pre-implementation of the checklist was 3.86%, and after 3.82%, which is very minimal differences. So there was no any statistical significant difference using the checklist over pre and post period, and it was quite different from what was the findings that were coming from the previous research that was observed. So how can we have findings from, from a randomized control trial and findings from a kind of a worldwide observational study? And when we are actually trying to implement it at scale, what happened there? And the likely reason for the failure of that was not actually used. And the reason for that was that there was a variation on the implementations that happened within the different surgeries. So, for example, there was a variation in length of time that they were using the checklist, on the percentage of items that they were checking during the surgery procedure, and how much it was introduced to the patients while and before and during the surgery. And some kind of more qualitative evidence that were coming at how much variable was the implementation at the executive level, but also at a kind of more granular nurse and doctors and other people, healthcare providers that were working in the hospital, was the theme from the qualitative work that happened was related to the fact that it was just appeared. It was something they were just doing for one day, and it was something that the staff felt that it was forced to use to them without actually being informed beforehand or being engaged or co-design the checklist. And this is not a new story, and this is kind of the case for the implementation science. We know that from when it comes from evidence research, evidence-based research, for example, from the development of the first phases of an RCT to when things are actually being implemented and being rolled out in routine healthcare practice, the gap that we have between actual research and real life, as was estimated from a paper in 2011, is a 17-year gap. And according to recent findings as well, we don't seem that this gap has been reduced within the last years. And this is not surprising, knowing how much is the time that it takes for example, to set up a randomized controlled trial, run the whole kind of phases of a randomized controlled trial and actually disseminate the results, and how much it takes to actually this become routine healthcare practice within a national healthcare system. So the whole purpose of implementation science is to actually bridge two worlds, is to bridge a world of research, where, for example, the intention is to maximize intervention efficacy, where there is a careful selection of patients, where they're specially trained, and there is a lot of funding in place to deliver the intervention or the policy. And on the health services research world, which the intention is not that, is the intention is to achieve sustainable delivery, widespread adoption. The practitioners that will run that, they will not be trained to use the list, and obviously we have limited funding. And because of that, I think because there's 17 years of gap that we have between research and actually routine healthcare practice, we're kind of lost in translation, like Bill Murray in this picture. And that's what we're aiming to do with implementation science. We aim, as Ellie said before in one of the definitions, we aim to close that gap. So the implementation science journal definition, for example, is that they define implementation science as the scientific study of methods to promote the uptake of recent research findings into routine healthcare practice. The National Institute of Health Research in the US defines implementation science as innovative approaches to identify, understand, and overcome barriers to the adoption, adaptation, integration, and scale-up and sustainability of evidence-based interventions, tools, policies, and guidelines. This is a kind of a more wider definition. So a kind of a definition that might work within what we are trying to do within the group, within the implementation science group, but as well that can encompass a little bit more the transitional and transferable aspects of implementation science, is that is like a type of a health policy and systems research concerned with the study of clinical and public health policies, programs, and practices, with the best intent to understand not only what is and what isn't working, so what is effective and what is not effective, but how and why implementation is going to be right or wrong, and to test these approaches to improve the implementation. And there are different implementation research terms that a lot of people actually might use in their everyday life, but they don't have the systematically systematically way of identifying them. So we have different implementation strategies of how methods and techniques can be used to enhance the adoption, implementation, sustainability of a policy. We have different implementation theories of framework. And we have different implementation contexts. And I think we touched a little bit about that around the barriers and the facilitators that could lead to a successful implementation of a policy, of a healthcare intervention, or a health service, a clinical program. And the key to the implementation research in order to make things more successful is like how you're engaging your different stakeholders that you're aiming to tailor your policy or the healthcare interventions. So there's a kind of wide consideration of stakeholders that they will start from implementers, policymakers, funders, to researchers and patients and service users. And also and this is kind of more like in a kind of decade emerging field, think a little bit more when you're designing a research study, not only in terms of how effective might be your policy or your healthcare intervention, but also how implementable can be. And there are these development of new type of hybrid studies, type of designs, where based on the amount of evidence that you have if a policy or a healthcare intervention works, you could look at you can look more at the clinical effectiveness of the intervention, for example, or more to the testing implementation strategies if you have enough evidence that the policy is working in different contexts. And I know that up to now, I'm discussing the framework as something that it leads from intervention development to policy action. But usually what we have in real life is that we have already a policy that is being rolled out within a city, within a borough, or within a healthcare system, because commissioners are really believing in this policy, or politicians or mayors. And then this takes, and then we are not able to provide the evidence, but we need to provide the evidence a little bit ad hoc. So we need to evaluate the assessment of the policy, and we need to think different about the evaluation. So this kind of hybrid type of thinking could actually help not only on the traditional path route of we develop in a policy or intervention, we test its effectiveness, and then we translate it into policy, but already with existing policy of how we will be able to evaluate all this, evaluate the effectiveness and the implementation of the policy, and also how we can make it more generalizable in different types of settings. And I'm in the last, I think, probably like 3-4 years, it starts to receive traction more kind of environmental related policy. This is a publication from Lancet Planetary Health on how we can advance climate change health adaptation through implementation science. And it mentions all the 4 different types of pillars that I briefly touched before. On how to identify stakeholders, how we can incorporate implementation strategies, how we can tailor it, how we can test for barriers and facilitators, and how we can look at dual effectiveness and implementation of a policy or a healthcare intervention. And this is something that we are trying to, this is something that we're actually working with my team at the moment in relation to the implementation of the ultra low emission zones in London. And we are trying to look at that in relation to population mental health. There's already ongoing work around the evaluation of ultra-low emission zones in relation to cardiorespiratory health. We are interested more on what will be the impact and the effectiveness of the ultra-low emission zones in relation to population mental health and health service use. And this is derived from some seminal publications that came from our team, that we did some epidemiological work trying to link, which linked air pollution with population mental health service use, and multimorbidity. And within that, we are looking by using electronic health records on the rapid evaluation of the ultra-low emission zone in terms of the effectiveness of the policy, and we have a reduction in terms of health service use, but reduction in terms of symptoms as well on the population level. But also as well, we're looking at the implementation of the policy tailored in relation to to patients who are attending psychiatric services, to psychiatrists and to other different stakeholders and commissioners within the psychiatric hospital that we are operating, the Maudsley Hospital, in order to understand better the policy. And as I said, the implementation science, just to summarize, offers a language and a way of thinking, and most of the people probably already doing much of the things that I mentioned, and how we can translate things from interventions to the real world is a complementary perspective to traditional effectiveness research. And we are aiming to capture how well an intervention is being implemented and how to tailor different strategies, because different strategies will not be equally useful or applicable. So it's a little bit of tailor your implementation, evaluation, and approach according to the needs of your study. And this is some tools and some workshops that we run we have developed, and some workshops that we run within the center on people that are more interested to learn more about implementation science. So we have developed an Impress tool about how to conduct successful implementation research. Thank you very much. I know it was a lot to cover and take in. I hope that I can cover more in your questions.